So for those of you who don't know me, I'm Christina, and that's Donna, so you can not mistake the two of us. And thank you for inviting us to speak with you. So today, Donna and I are going to try to attempt to give you a brief overview, whirlwind overview of kind of the issues that we see in kids and adults with CDG, and give a little bit of advice as to what maybe you guys can do about that. But one big disclaimer that I want to start out with is that every single individual with CDG is unique. And so every person really needs an individually tailored care and individualized medicine, basically. And so it's really important that although we're giving you advice, you really need to follow up with your own physician and really talk about your child individually. So the way we organize this talk is what we call by systems, body systems or functional systems. And as the speakers before me that are very amazing have already emphasized, glycosylation, the process that's going wrong in CDG, touches vast portion of the body and can cause lots of problems in many, many different systems. So we organize our talk this way and like to start out with genetics. The reason is because the way we kind of think about CDGs is that they are genetic disorders. But what does a genetic disorder really mean? From our point of view, a genetic disease is a disease that's caused by an abnormality in a person's genome or genetic code. But what is this genome or genetic code actually? Sometimes it's a little confusing. So the genetic code we like to think of is like an instruction manual that the parents pass on to their kids. And it's the manual that basically tells you how to make yourself and how to allow your body to function. So it's very, very, very important. And in a genetic disease, there is a misspelling in this manual that causes the problems. And I want to emphasize that this misspelling is not because of something that you did, it's not anybody's fault, it's not something you ate, it just happened. I want to also give you a little bit of more visual as to what exactly is the genetic code. And so I put up this picture. So actually in every cell, most of the cells in our body, we actually carry a full copy of our entire manual. And this is encoded in in molecules called DNA. And because we're pretty complicated organisms, you can imagine that this code is really, really long. In fact, about 3 billion letters long. And because it's so long, it has to be organized in a way. And the way it's organized in each cell is in structures that we call chromosomes here. And if you look into one just little part of the chromosome and stretch it out, you can see that it's made out of a string of molecules that there are 4 types of, and each molecule, each specific type, we just label with a letter, A, T, C, G. And it's the order in which these letters are placed that basically determines what it's saying, just like in a book. It's the order the letters are in that lets you know what the book is actually telling you. And so, this is kind of our genetic code, and you have this in every cell of your body. And in this picture, this is actual picture of DNA that is seen in one cell of one person under the microscope after it's been processed, visually. And the only thing I really want you to see is that we have 23 chromosomes, so I like to think of them as books. But we also have 2 copies of every chromosome, so 2 copies of each book. And you get one of these copies from your mom, and you get one of these copies from your dad. And why am I telling you this? It's because this allows us to understand inheritance patterns and why genetic diseases can be passed on from generation to generation. And in CDGs, the majority, not all, but the majority of the conditions are inherited in a pattern that we call autosomal recessive. And what does autosomal recessive mean? All it really means is that in order for a person to be affected by the condition, both copies of that particular gene that's causing that condition have to have a misspelling in them. And so what does this mean for you? So in a recessive condition, it means that usually, in most cases, both mom and dad carry, everybody has all the genes. They should. And so they have two copies of the gene, one that they got from their mom and dad, and one of those is abnormal, which is represented in red here, and one of them is normal. Same with mom. And so in every pregnancy, there's a random chance, so you only pass on one of the copies to your child, and then dad passes on the other copy. So there's a chance that dad would give normal and mom would give normal. Or it could be that dad would randomly give his abnormal and mom would give normal. And then, or it could be that dad would give abnormal and mom would give normal. Or it could happen that both mom and dad give the abnormal, the misspelled copy of that gene that causes that condition. And in a recessive disease, the only time that the child is affected is when both of the copies are misspelled. And so if you kind of just tally it up, that's 1 out of 4, or 25% chance in each pregnancy. But again, to emphasize, not every single CDG is inherited in this pattern. So if you have a more rare type, we can talk about what its pattern is. It depends on which gene. So knowing this information, what does this actually mean for you in a practical sense? So if you actually know the genetic change that causes the disease, you can predict what we call the recurrence risk, which just means the risk that a future pregnancy will be affected by the same disease in your family. So either have you and your partner having another child, or even beyond that in your family. There are ways to calculate that. And in addition, if you actually know the specific change, the misspelling in the gene, you can use that information in future pregnancy planning in ways with prenatal testing, which means testing of the fetus during the pregnancy to determine if the pregnancy is affected or not, and then making decisions based on that. Or even in pre-implantation diagnosis, which just means that you can actually test and decide on, before the pregnancy started, if you're willing to go through methods such as in vitro fertilization and such. So this really empowers you. So now, because this is quite a whirlwind of topics, I'm going to move on to the next system, which is eyes and ears, ophthalmology and audiology. So because a lot of the eye structures are glycosylated, we do see a lot of symptoms with eyes in different types of glycosylation problems. And so here I'm just listing the most common symptoms that have been seen in patients and individuals with CDGs. And the first thing that is noticed a lot of times is abnormal eye movement. In fact, it was already mentioned earlier in the second talk. And the two types of abnormal eye movements that have been seen most are one called strabismus, which means that they're not, the eyes aren't aligned together, and that can impact vision, as we talked about earlier. And this is a picture of that. And another type of movement disorder that's pretty common in CDG is nystagmus, which just means that the eyes kind of move back and forth in an uncontrolled fashion. We've seen dry eyes in several types of CDGs, and that, if that's found, is amicable to treatment. We see droopy eyelids in a lot of types of CDGs. We do see that in some types there's corneal clouding and cataracts, which is a clouding of the lens that can impact vision. Nearsightedness and farsightedness can happen as well. And a lot of times there are actually structural abnormalities in the eyes. Sometimes the eyes are too big, sometimes they're too small, sometimes just parts of the eyes don't develop normally. And even the back of the eye, which is the retina, may not develop normally, or there might become problems later on as they grow older. And the pressure in the eye has been noticed to be elevated in some types of CDGs, which can cause nerve damage. So it's important to to know about that, and that's called glaucoma if you have high pressure in the eye. But I want to emphasize again, every individual is an individual. And so not all of these findings are seen in all children or adults with CDG. And so, what do you need to do? Well, because we know that eyes can really be impacted in a lot of types of CDG, we really think that ophthalmology should be one of your team members. And so it's important, once you know that your child has a CDG, they should go and see an ophthalmologist and follow them routinely because some of these problems develop over time. And if it happens that your child or your family member has poor vision, there are other people that can also help in addition to ophthalmologists, such as vision specialists, functional specialists that can help adapt the environment and help your child function to their best ability. Moving on to the ears, audiology. So before, it was thought that CDGs didn't really impact hearing a lot, but in the last 5-10 years, it's been noted that in some rare subtypes of CDGs, there has been hearing problems. Sensory neural hearing loss has been reported in a couple of types, and there's been some abnormalities found in transmitting sound and signals into and within the brain as well. But this is only noticed in rare types of CDGs, and sometimes it's only detectable by specialized testing. But for some of the cases, hearing aids and cochlear implants have actually been beneficial. But I don't want to raise too much fear, because if your child has a developmental problem, it's standard of care to check their hearing. And so that should have been tested. And if your child doesn't have developmental problems, they should be able to tell you if they're having trouble hearing. So that is just something to be aware, that if they're having hearing problems, it could be related to their CDG. Moving on to hematology. And in hematology, what I want to emphasize is bleeding and clotting. Because like a lot of other systems, a lot of the factors involved in bleeding and clotting are glycosylated. So in our bodies, it's really important to have a very good balance between bleeding and clotting. Because if you get an injury, you definitely need to be able to clot it off and not bleed out so that you can not die of bleeding. But at the same time, it's important to allow your blood to continuously flow and not just be clotted all the time, because you need your blood to flow throughout your body to deliver the nutrients and to eliminate the waste and give you the body oxygen and such. So it's important for you to be able to do both, bleed and clot. And in fact, the body has developed a very complicated system to allow for this homeostasis to happen, the balance between bleeding and clotting to happen properly. And many of these procoagulants, which are factors that allow for bleeding, or not bleeding, but blood to flow, not clot. It's the opposite. So procoagulants allow you to clot, and anticoagulants allow the clot to be dissolved. They are glycosylated. And so because both sides are impacted, it's really hard to really predict if your child is at risk more for bleeding or for clotting. Actually, in fact, it's kind of known in the most common type, in PMM2, that they're at risk for both. And it's hard to predict in one individual if they're going to bleed, or if they're going to clot, or if they're going to do both. And in one study, it was 14%. 14% bled and 14%. And you could not really predict well based on measuring. But you really just need to know that they're at risk. So now that you know that, what do you do? Well, it's important to really know that, and that in itself is power, that you are at risk for bleeding and clotting. And so if you know that you're at risk, you should know kind of the symptoms to look out for. Especially, well, bleeding is pretty obvious. If you're bleeding, you'll know that you're bleeding. But if you're clotting, sometimes that can masquerade as other problems, such as fractures or even just a bruise. So you need to know what kind of symptoms to look out for. And some of these symptoms, if you have a clot, for example, in an arm or a leg, called a deep venous thrombosis, or DVT, you could see swelling, pain, or discoloration of that arm or leg. Or if you have a clot in the lung, it could be shortness of breath or chest pain. Or if you have a clot in the kidney, it can result in bloody urine. Or if you have a clot in the brain, you can have change in mental status. So if you see these, although it could be due to something else, and definitely that could be the case in that situation, you have to also know that it could be a clot. And that's something you need to bring up to your doctor and bring to your attention and take seriously immediately. And for whoever else takes care of the individual in your family's CDG, they need to know this too. So it may not be always the parents that's taking care of them. They need to know, and they need to know to take it seriously and bring it up to the doctors if they're at risk. And also you want to carefully consider, kind of think about, is it really worth it to do that intervention or do that thing that puts you at higher risk for bleeding and clotting, such as elective surgery or immobilization for some reason, or even some hormonal therapy like Dr. Miller was talking about. And keeping well hydrated seems to help a little bit. And then let's talk a little bit about pediatrics. And the two topics that I mainly want to talk about are vaccinations and growth, and less so about growth because that's already been covered. But vaccinations and immune function has been kind of an open question in CDGs. And maybe one of the reasons is because it's complicated and variable. So a lot of the cells that help fight infection are glycosylated, just like everything else in the body. And when we look at the immune function, it's quite different between different types of CDG. And even in different patients with the same type, we see a variability. Some are at more risk for infection. And in one type, and we're seeing even a few more, it seems like they're even protective. Having that is protective against viral, at least, infections, which is kind of interesting. But about immunization, so we've seen 15 types. I'm excluding the NGLI ones here, but we've also seen the NGLI ones. So like many patients with CDGs of different types at the NIH Clinical Center. And every single one of them actually followed a routine vaccination schedule recommended by the AAP, and most of them actually got flu shots even. And none of them had a proven adverse event. And in fact, we looked at some of the blood measures, and the majority of them actually responded. Not everyone, but the vast majority responded to the vast majority of vaccines. So that's a good thing. It looks like there's a benefit and less of a risk. So what do we think you guys should consider? To follow the routine vaccination schedule. But do consider using Tylenol or Advil to prevent fever after vaccines, because some kids with CDGs are predisposed to having complications with fever, such as seizures or other problems. So do consider using that. And they have been vaccinated against live vaccines as well as inactivated vaccines. They're varicella. So I would suggest. And in terms of growth, I'm not going to go over this too much, but like Dr. Miller said, most children do grow poorly. And it may occur prenatally in some rarer cases, but it typically occurs during infancy or even later childhood. And why does this happen? There are many reasons. One major reason is maybe that there's an imbalance between the intakes, the amount of calories they're intaking, and the needs that the child actually require to grow well. And there are a lot of reasons that the child is unable to take enough calories. It could be malabsorption or diarrhea or feeding intolerance, vomiting, reflux. And so it really kind of depends. And needing more calories because sometimes they're having more illnesses, maybe because their heart is affected or some other organ is affected. So it's really important. That's one major reason. And the second, it could be just that some individuals have a lower genetic height potential. And we saw that I saw that in one of the papers that half of the older PM2 patients had a normal body mass index, so their weight to height ratio was normal, but their heights were less than the 5th centile. It could be an endocrine issue. And there are actually some CDGs that have short stature and what we call dwarfism, actually. So what do you do about that? Again, depends on the reason for poor growth. Nutrition, we already emphasized. very important if you're having this issue to involve a dietitian, nutritionist, because they can really adjust the number of calories, the type of formula, if you're using a formula, the density of feeds, timing of feeds, a lot of different things, and even alternate ways of introducing calories in addition to feeds, and Donna will go into that a little more. And if you have some other complication like protein-losing enteropathy, there may be a medication that could be helpful. For example, in MPI CDG, it seems that mannose in some cases or heparin has been helpful. And again, timing of feeds. So now I'm going to introduce Donna. She's my wonderful mentor, actually, and to finish up this.
Great. So we were just going to do this as a continuum. So I'm doing GI. And I'm going to go back. We talk a lot about nutrition, and Brad did too. Really, there are many children who fail to thrive despite very heroic efforts by their families to feed them. And many of you, I'm sure, know reflux and persistent vomiting and formula intolerance is something that you've seen in your kids, and typically they grow out of. Some children have G-tube placement, Nissen fundoplication, which is basically tightening the sphincter between the stomach and the esophagus, the tube that goes down, so that the kids don't reflux so much. And really, what you hear is that parents resist often the placement of a G-tube or Nissen fundoplication because they don't want their child to have surgery. Completely understandable. On the other hand, if someone's spending 12 to 14 hours a day feeding their child and not playing with them because they're spending all their time trying to get food in their mouth to get them to grow, let's think that through one more time and figure out whether there's a better way. I've never heard a family who's made a decision to do a G-tube placement say, oh, that was the biggest mistake I ever made. 99% of the time they say, wow, really changed our lives in a good way. I'm not advocating everyone gets them. I'm saying that it's put on the table to seriously consider it. Typically, feeding issues in most types of CDG decrease by the age of 3 years, and many affected adults will eat regular diets. We actually are really blessed to have a couple of adults in here, and we're so glad to see them, and let's see what they have for lunch. Liver function, we talk about liver function, and I'm going to move back. Yesterday we talked about CDG1B or PMI, MPA, you never get it in the right order, CDG. I'm going to take those out of the picture because I'm going to talk about the transaminases or the hepatopathy or the liver dysfunction that many of you in this room, your doctors have talked about. And what they're doing is they're looking at a blood test and they're seeing elevated transaminases, which is, the acronym is AST and ALT, two different tests that you see when you do a complete blood panel, and they go up. Before the diagnosis of CDG, physicians freak out, parents freak out, grandparents freak out because they see these going up and often can go up very, very high. In a child without CDG, it is worrisome, and we have to figure out what's going on as a pediatrician. But in a child with CDG, it's the maturation of the liver, the ability of the liver to make glycosylated proteins, which is where they come from in the blood, do it well and get them out of there into the blood. That system isn't so good, and in little people, it doesn't have a lot of reserve. So the cells break because they're working so hard, and that's what gives them those elevated AST and ALTs. They go up, sometimes can go up really high, make us all a little nervous. Almost always come back down by the age of 5. You can see them come down. May bump when the kids get a little sick, go back down depending on the type. But there have been kids, especially before the diagnosis, who have gotten liver biopsies. If someone wants to biopsy your child because their liver functions are too high, please call one of the clinicians in the room and we will discuss that with their physicians because I would really hate for that to happen in a situation where 6 months later they're going to go back down to a reasonable level. Protein-losing enteropathy is really bad diarrhea that causes significant failure to thrive, and in the case of the 1B, individuals can be treated with mannose with some caveats. So what to do? Again, discuss nutrition with your pediatrician or internist and consider consultation. Monitoring liver function tests and albumin. Albumin is another protein made by the liver. It's not glycosylated, but it gets boogered up in the machinery because the liver cells are so busy trying to put out all these glycosylated protein, it gets trapped. And so often your albumin can be low. It also can be a reflection of nutrition. And so people will look at that, and it's actually a very important protein because it keeps all the fluid in your blood rather than outside of your extremities. So I suggest that if someone gets the diagnosis of CDG, and often it triggers people looking for the diagnosis of CDG, liver function tests should be checked in the first couple of years after the diagnosis, and the liver functions are elevated 3 to 6 months, probably every 3 to 6 months. Once those liver function tests come back down, if you get them once a year, that's great. Get them once every 18 months or 2 years, you're good. Or if the children are sick, people will look at them. Cardiology. Pericardial effusions is fluid between the muscle of the heart and the sac that contains the heart. It can be seen in children, it has been reported in children with PMM2 CDG, typically in infancy, typically clinically really not impactful. In other words, children don't have cardiac issues. There are some children, there's now 3 or 4 reported cases where the children have significant fluid. The children are sick, this is not a secret. And the diagnosis is made by ultrasound of the heart. So every child with CDG should probably have an ultrasound of their heart at some point along the way, just to make sure that the cardiologist knows what they're seeing as a baseline in case something changes. I don't expect that to change. Cardiac health is usually very good in individuals with CDG. We're all grateful for that. Although cardiomyopathy has been reported and diagnosed by ultrasound, that would be something your pediatrician would say or your internist would say, I'm listening to the heart, this doesn't sound right, let's get an echo, we'll be able to see it like that. So, let's see, renal, that's kidneys. So, kidney disease, we used to always say, like the heart, that the kidneys do okay in CDG. I think in the majority of types of CDGs, we have not seen kidney issues. In PMM2 CDG, we do see some changes by ultrasound of the kidneys. Little hyperechoic, which means that they bounce back, the signal bounces back because they're a little bit denser, and some cysts in the kidneys. Typically, their renal function maintains. We have adults with PMM2 CDG who their kidneys are doing fine, their kidney function tests are good. But I really think it's important to get a kidney ultrasound also sometime afterwards, not an urgent reason, after the diagnosis is made. And the reason is, let's say someone sees those little cysts, they know they're there. Whereas 6 months later, the kid gets a fever, nobody knows where that fever is coming from, they echo these kidneys, and everyone begins to panic, oh my goodness, they have these cysts in these kidneys, why is that? So those two, the cardiology and the renal ultrasounds are great because then you have a baseline, you know where it is when the kids are doing okay, and that allows you to sort of come from there. There are reports of proteinuria. I will not minimize that. Actually, that's protein in your urine. That's checked in a typical urinalysis done at a regular pediatric exam. You get somebody to pee in a cup or a bag or however you get them to pee, dip the stick, they can see proteinuria and go from there. So that is not some specialized test. That's something that every child has everywhere. Typically, I think they do it at 3. I don't remember what the academy says, and we'll go on from there. So renal ultrasounds when the diagnosis is made, and then urinalysis, pediatric exam unless something comes up. Dermatology. The dermatology story in CDG is important for people who diagnose CDG and children who have hypohidrosis, because I think it impacts their health. Everything else is just interesting, but not going to impact the children. So dimpling, which you can see, dimpling you can see here, excessively dry skin, ichthyosis, which is very scaly skin, thanks Ava, and the cutis laxa, which is this very stretchy skin, and also hypohidrosis, which is actually the inability to sweat. And those children need to keep cool and stay hydrated. Moisturizers for many of these, and this you just think is really cute. And so that's how that goes. What do you do rehab. We're going to have a lot of people talking about OTPT and speech. I'm a huge fan. And again, I'll say it, a huge fan, and should any school system stop me from getting those things, Mark said it out loud, please call one of us and let us write a letter. because we think they're important too. Osteopenia, like bones, Brad talked about kyphoscoliosis, curvature. Scoliosis is the S of the spine. Kyphosis is when the spine curves like this. That can begin early in life and become progressive. The way people manage that is they keep the children in good positioning if they're in a wheelchair. They keep them well supported in their wheelchair. Truncal strengthening exercises. Let them stand if they can stand as much as they can to get them there, because that's going to keep their spine straighter in the long run. Joints may be hypermobile, really flexible. I'm not hypermobile, I'm way too old for that. Early in life, but contractures where you can't completely stretch them out can occur later in life, and muscle wasting may occur. PT and OT can make sure those contractures, the more you stretch them, the less likely it is that they're going to be contracted, and that's important. Abnormally formed bones, bone dysplasias, are seen in some rare types. Speech therapy, huge fan. Speech therapy is two parts, right? Oral motor function. In other words, how you chew, how you swallow, how you get the food from there down to your stomach. That's important. Communication options, second important part of speech therapists. So we should make sure that all of our kids have at least attention to both those sides if it's appropriate for them. Physiatrists is a really cool medical specialty, and pediatric physiatrists rock. These are people who understand how to give children appropriate physical therapy, appropriate services, appropriate equipment, all those things. This is an MD who does this for a living and then gives directives to the very smart physical therapists, speech and occupational therapists. And so if you haven't seen a physiatrist, you don't have to run out and see one tomorrow, but consider that if you're worried, especially during a growth phase of your child or a time of transition, I think it's important. Mark gave us neurology. We won't talk about developmental delay. Axial and truncal hypotonia, the low tone you all recognize. Ataxia, poor balance, dyspnea, difficulty with fine motor tasks, oral motor dysfunction, dysarthria, slurred speech, peripheral neuropathy, all things that are seen. Many children have different brain structures. Mark already showed the very small cerebellum here. Here's a normal cerebellum up here. Here's your nose. Here's the back of your head. Y'all know this. You probably could give me lessons. All children with PMN2 CDG have cerebellar issues. I don't actually say all very often, but I will say this. And so they may function completely fine, but they probably have some stories that they're telling us. Other types may have difference in brain anatomy as well as myelonations. I think the acute problems that we need to remember, many children with CDG have seizures. Many of you in this room are more concerned at seizure issues than I am. Kids may have seizures early. They may vary from very subtle behaviors like a little subtle eye movement or a twitch to whole body movements. Some are responsive to medications, others are more difficult to treat. You diagnose them with EDGs. If you think you're seeing them and they can't get them on an EEG, one other technique is to do a 24-hour monitoring EEG where they're hooked up and you're watching, and when the thing occurs, let's say it's an eye twitch or a movement or a hand movement, you click it on the, whatever you do. Yeah, you click the button and then it marks it and they can look at the brain signaling in that area. So anyway, seizures can be relatively subtle. Stroke-like episodes have been seen in several types of CDGs, and here's a scenario. I'm going to tell you the story. So, child goes out to play in their walker, takes a tip, gets a little bump on the noggin, kid looks pretty good, doesn't have a concussion. Next morning wakes up, mom says, wow, can't move his right leg. It's kind of weird. Maybe he hurt his leg when he fell down. Over the next 2 to 3 hours, can't move the right arm, face looks a little different, kid goes to the hospital. That's the beginning of a stroke-like episode. That fall on the sidewalk may actually be a high fever, may have been a little seizure, or may have been nothing at all, and these stroke-like episodes happen. The kid goes to the hospital. That is the appropriate place for these children. Sometimes the physicians freak out, and sometimes they're smart and they read the internet, and that's good, or they call one of us, which is wonderful as well. Typically, there's full recovery. I like to see the kids very well hydrated by IV. We don't usually feed them because a lot of times they're very groggy after this happens. Keep their sugar up. So Sometimes we, especially in children, we just give them a little bit of sugar to sort of keep them going when they're not feeling well. I like to keep the kids up 80 or 90 or even 100, just because the blood-brain barrier doesn't have, and Lynn hates this when I'm saying it, but it's okay.
I think we need to be specific about types when we say
That's true.
that's all.
Okay, I'll take it back. And, but hydration is good, and we can talk about that other question later. And just to pull it through, and then they recover. Sometimes it's 2 hours, sometimes it's 3 days, sometimes it's 3 months. I'm really good gathering, aren't I? So this is the end. All the affected children and adults are different. I think Christina emphasized that very clearly. Assemble a medical team that's right for your child. It doesn't have to be every expert. It can be the ones that work for you. Ask for a letter from your physician to bring to the emergency room, especially when you're traveling, so that they know, so that someone can at least read about what's going on. And really, I think that we're always learning, and the future holds great promise, especially with this incredible community. I want to thank Andrea, the CDG Care Group, for organizing this meeting and for inviting us, children and adults and families that are here today. And I guess in my own heart, the many family members who have supported the interest and the important ethics of CDG over the years, 24, 25 years since I saw the first child. There was a very powerful infrastructure to this as well. And this movement is amazing. So thank you very much.